Good evening and welcome to the second educational webinar, Allergy Expert in Action, Alexa. This webinar is supported by Nutricia Specialized Nutrition. The webinar will take the format of two individual presentations. These will be delivered by our guest speakers, and each presentation will be followed by a dedicated question and answer session. You have a chat tab that you can use, but please submit your question using the question tab that you can see on the right of your screen during the presentation. You can send your questions while the speaker is presenting, and the speaker will then reply to as many questions as the time will allow. To start the webinar, we would like to welcome our first speaker, Dr. Ahmad AlKhabaz, for his presentation, Challenges with CMA Diagnosis. Dr. AlKhabaz works as the head of Pediatric Allergy and Clinical Immunology Unit in Mubarak Al-Kabir University Hospital in Kuwait. He is also the head of unit and consultant in pediatric and in allergy, asthma, and clinical immunology, and a KIMS tutor and chair of the exam committee. It gives us great pleasure in welcoming Dr. AlKhabaz to join us for this evening. Okay, you can go ahead, Doctor.
Okay, good evening, everyone. Thank you, Lina, for the introduction. It's my pleasure to be among you today, and thank you very much for the kind invitation. This is the age of the corona, unfortunately, so we are cautious, but it gives people opportunities to try different ways of communicating. The title of my talk, as you mentioned, is about carbon protein allergy as a diagnostic dilemma. Overall, we think that carbon protein allergy is not too difficult to diagnose, but in fact, it's not as easy as people may think because of the variety of different type of diagnosis of carbon protein allergy. So I'll go ahead with my slides and see how this progresses. So I'm going to talk mainly about some issues about the knowledge about carbon protein allergy, pathophysiology, and diagnosis. Then about some of the basics that are important for the diagnosis and management. The symptoms role, the diagnosis as well, and the diagnostic tools, and about forced tests as well. Okay, so the problem with carbon protein allergy, as it is with many pediatric topics, in the young age, the tools of diagnosis as well as the adequate knowledge sometimes is not available, especially in the Middle East region, where we have big problem regarding basic studies about the prevalence, the pathophysiology, or even diagnosis and management of such a critical or very important common diagnosis, even though it's actually increasing diagnosis as well. And makes it very hard for people to follow up and diagnose their patients as well. It's a worldwide common problem, as we all know. There are variable symptoms from milder colic symptoms, which are difficult to measure, let's say, or classify in a very objective way in young children and could be caused by many other pathologies, to a very specific symptom where you have, for example, IgE mediated, where this could be a cough or even as severe as angioedema and unfortunately anaphylaxis and severe anaphylaxis and death. So it's a very wide range of symptoms. The sensitivity of diagnostic tests in that age, as we all know, are very little. So that keeps us in a difficult situation regarding diagnosis. We don't have a very sensitive and specific test to give us that diagnosis. As well, we all know that the perceived carbon protein allergy diagnosis or allergy diagnosis in the community is actually very high. In reality, it could be 4 times or 5 times higher. Let's say maybe people think when you go through parent-led questionnaires that about 30 to 40% of children or the population would have allergies because allergy is such a wide symptom. In fact, confirmed cases of carbon protein allergy range between 6 to 8%, or even, in fact, this is like total food allergy. When you go to carbon protein allergy itself, we talk about 2 to 4% in many studies. So the variability of symptoms and as well the common kind of wording of the word allergy rather than a specific symptom of allergy makes it difficult to identify. Many children, unfortunately, would go on special diets with special formula sometimes, or even unusually difficult diets where they give them anxiety and difficulty in growth because of the fear of anaphylaxis and fear of chronic protein allergy, when in many cases not as necessary to be so restricted, since it's only common protein allergy, not an allergy to a lot of things. I specifically do that or mention that because many children go through a diet of avoid wheat, milk, egg, soy, fish, nuts, all the common allergenic foods, just because we cannot identify the cause. And that's a source of great concern and worry for both doctors, parents, and not healthy for children, obviously.
Excuse me,
We did
doctor. Could I please ask you to talk a little bit louder because we are receiving comments that the voice is not clear.
Okay.
Sorry
I'm
for
trying.
interrupting.
Okay, I'm trying to raise my voice, but is that better?
Yes, that's much better. Thank you so
Okay.
much. Sorry for
Okay.
interrupting.
No problem. So nutritional problems such as rickets, I've seen a couple of cases at least where the children have presented with rickets because the mother avoids calmic protein and a child who's only breastfed to avoid symptoms. At the same time, they would not go on supplementation of vitamin D. The unmeasured complications of calmic protein allergy are very common, and that's specifically I'm talking about the anxiety that goes through the family, the behavioral problems associated with that, eosinophilic esophagitis, which presents even late childhood or early adulthood, where it's a complication of chronic protein allergy or other food allergy that's being missed. We did a survey in a tertiary hospital or many tertiary hospitals in Kuwait with my colleagues and myself regarding the knowledge among hospital-admitted patients with chronic protein allergy. And we had about 38 questions. We found that the mean correct answer was about 22.2 answers. So about 60% only of tertiary care hospital children in Kuwait, the pediatricians actually had adequate knowledge regarding the chronic protein allergy diagnosis, management, and prognosis. If you have an accurate diagnosis, obviously you can be done through the risk of physical complications, nutritional complications, rickets, decreased bone mineralization, anemia, poor growth, low albumin, immediate clinical reactions. It could be as subtle as a cough, or could be severe as later on as anaphylaxis and death, and severe gastroenteropathy leading to malabsorption. This is not really a comprehensive list, but just to show many of those complications will present later on. So we know those children would have low bone mineralization as they become adults and older children. A bit about the basics of chronic protein allergy. So we'll go through now a poll question, if you don't mind to switch into the poll question. So it's a basic question. Whey protein makes about 80% of chronic protein. Can we run through the poll, Helen? Can you submit your votes, please?
Yes, the poll has been set.
So we'll wait for the results. Did you get the results within a few seconds for the results? Yes?
You can see the live results in the polls. 58% of people said yes.
Okay. So about 60% say that wheat protein makes about 80% of cow's protein. And unfortunately, this is wrong. Wheat protein does not make 80% of cow milk protein. In fact, the wheat protein makes about 20% of cow milk protein. The formula that you have in the market for milk is actually based on wheat protein mostly. And the opposite contrast to this is that the more severe cow milk protein allergy reactions occur to casein proteins. those proteins are more heat resistant and are more allergenic, but they don't make a large bulk of the percentage of caloric protein allergy. The majority of caloric protein allergy is caused by B proteins. Specifically, we talk about beta-lactoglobulins, as you can see, and alpha-lactoglobulins as being the main protein causing the allergy. Okay, the proteins in the wheat proteins are more hydrolyzed and affected by heat. So the proteins that cause allergy are in fact a small glycoprotein between 10 and 70 kilodaltons. They are usually heat resistant and acid stable to cause an allergic reaction. The major allergenic foods, as you probably all know, in about 80% of cases or more, are milk, egg, soy, and wheat. But in adults as well, you get more predominant peanuts, nuts, shellfish, and fish. And once you have a single allergy for IgE disease, you get a high risk of other food allergies as well. Okay, and the epitope composition of the proteins could be either linear or conformational, B cell versus T cell epitopes, and that affects the immune responses. But that's a different talk. Okay? I'm showing you this image just to show you the response. You have to keep in mind this is a very important take-home message. Okay, the younger the child and the more severe the eczema, the higher the chance of association of caloric protein allergy with the symptoms or the signs of eczema. Eczema is a very unique sign, and the symptoms with that are unique as well, because they can be caused by IgE-mediated or non-IgE-mediated caloric protein allergy. For example, urticaria is an IgE-mediated reaction. Okay, it doesn't happen in non-IgE-mediated reactions, but with eczema, it happens with both IgE and non-IgE mediated. And the response you can see could be remarkable in about 2 weeks of changing the formula in those specific cases. Okay, another poll question, please. Okay, so the question here, the majority of caloric protein allergy is non-IgE mediated.
About 70% of the people are answering yes.
Okay, are we done, Helena, or should I continue, or should I wait?
Yes, you can continue.
Okay. So 70% say that the majority is non-IgE mediated, and that unfortunately is not correct either. Okay, so obviously it depends on the studies you go through and where you read. But in some studies we have an equal number of 50 to 50%. In many studies, we talk about the majority of IgE mediated common protein allergy caused by IgE disease. Now, it could be because the symptoms and signs of non-IgE disease are difficult to measure, and diagnosis in that particular group is actually more difficult because we don't have a sensitive test or specific test to do that. But the studies at this time do show that the majority of common protein allergy is IgE mediated. Okay, the symptoms in IgE mediated disease, as you can see from the table, occur immediately within minutes to hours, as opposed to days to weeks on the non-IgE mediated disease. The IgE disease is life-threatening because you have anaphylaxis, but obviously severity in non-IgE disease is never anaphylactic, although can be more severe, affecting the skin and GI tract. IgE disease lasts much longer. IgE disease could be for life as well. In many of these cases, including common protein allergy, although very rare, it can persist into adulthood life. But non-IgE disease usually is not lifelong, and with common specifically resolves between 1 to 5 years, the majority around 1 year, and some at 3 years, and rarely at 5 years. Okay, maybe a bit longer, but overall that's what we have. Okay, disease with IgE disease includes other IgE disease, so asthma, rhinitis, urticaria, eczema, included in those spectrum of common protein allergy caused by IgE. But with non-IgE disease, there's no association specifically with those diseases. More with maybe eczema, eosinophilic esophagitis, and GERD. So mostly GI and skin manifestations of non-immediate response. We talked about anaphylaxis. Nutritional support in IgE disease usually is more because you have multiple food allergies as compared to non-IgE milk disease where there are less multiple food allergies other than milk. Doctors in charge, depends on where you work, but with IgE disease, there has to be an allergist involvement in this case. If it's not IgE mediated, many doctors can manage that. Sometimes general pediatricians, sometimes gastroenterologists, or allergists, or even family doctors, if it's not so complicated. Okay? The formula type as well is variable, and with non-IgE disease, we talk about extensively hydrolyzed formula as your first choice. If it failed, then you move on to amino acid formula, or in some special cases, where eosinophilic esophagitis is an example, you have to go with the first formula as being amino acid formula. The same with IgE-related disease, depends on severity, if it's a life-threatening anaphylaxis, if it's an ICU admission, or if it's a failed treatment, you move on to amino acid formula, or in some cases, you start with amino acid formula, sorry, if it was an life-threatening reaction, okay? Testing for non-IgE-mediated disease, we don't have a test, unfortunately. We do have some tests I'm going to talk about, but there's none that are specific or sensitive enough at this time. With IgE disease, we do serum testing and we do skin testing, but you have to be careful because, because if you do blood testing in the private sector, if it's not the specific immunocap testing, where the specific IgE test is repeatable and reproducible, the result can be confusing, okay? So if you have IgE disease, okay, then you have a higher risk of persistent subclinic protein allergy. It usually presents below 2 years of age. You can get urticaria with a challenge as well. You can get exposure at the maternity hospital in many cases. And usually if you have IgE disease to milk, you have a high risk of sensitization, which means IgE disease or IgE antibodies to egg protein as well, okay? As opposed with non-IgE disease, it's associated more with soy, for example, allergy, not with egg allergy. IgE presence increases your chance of developing asthma by twofold, rhinitis by twofold, and eczema by threefold as well. We'll come now to diagnosis of common protein allergy. And I mentioned before that that allergy is caused by protein. It's not by carbohydrates. It's not by fat. There are rare cases of carbohydrates causing peanut allergy, but 99% of the cases or more, we talk about protein only. It's an immune-mediated reaction as opposed to intolerance. For example, lactose intolerance is not a lactose allergy. It's an intolerance to the sugar. And the sugar there, because of the lack of the enzyme to digest the lactase if absent, you get the symptoms, usually GI symptoms, bloatiness, diarrhea, but never skin manifestation or anaphylaxis. And with protein-associated common protein allergy or common protein allergy, you have IgE and non-IgE mediated, and then we go through the test. The BAT stands for basophil activated test, and we'll talk about that a little bit later on. Okay, another poll question, please, just to make sure you're still awake all. Yes, I can't see anyone, so I can't judge. Serum-specific IgE testing has high positive predictive value for clinical diagnosis of common protein allergy. So I mean by that, if you have a positive test, it means a high chance of a clinical reaction. True or false?
People are still
Okay.
answering, but we have 50-50.
Almost 50-50. That's an interesting one. That's a very interesting one. And the answer is actually a 50-50 answer, but I'll give you a more specific answer. It depends on the number, the age, and the protein you are testing. Overall, the IgE testing has about, let's say, 50-60% positive predictive value, which is not high. In fact, it has a high negative predictive value. So if you have a negative test, you're almost sure you don't have common protein allergy, right? But you're not sure yet. What I mean to say, you have to keep in mind that common protein allergy, the test is a tool that helps, but it's not a tool to diagnose. The test tells you you have an IgE antibody, doesn't tell you if you have a diagnosis of common protein allergy. Okay, and they're not the same. I'm going to show an example of that in a minute. Okay, so clinical diagnosis could be delayed onset, specific symptoms, acute symptoms. If you abstain from the ingestion, you get improvement of the symptoms, for example. Okay, you do a trial sometimes in cases which are not IgE mediated, non-IgE mediated disease, I mean, the onset is delayed, and usually it's by trial and error in non-IgE mediated disease. If you abstain, you introduce the formula and the milk again into the breast milk or to the formula, you get the reoccurrence of symptoms immediately or slowly. Okay, if you don't improve with the symptoms, then you have to go into a special formula, elemental formula, after giving extensive hydrolyzed formula in the first 2 to 3 weeks. Only in special cases, we don't do that. If you, like Ahmad, like if you have a eosinophilic esophagitis or failure to thrive, for example, okay, you start with the amino acid formula. And if you fail the trial of extensive formula as well, in other cases, after 2 to 3 weeks, you refer to gastroenterology or to allergy, depending on the GI symptoms or other like eczema symptoms. Okay, you refer for GI in that case for testing as well, investigation, and refer for allergy for that reason as well. Patch testing, and we'll talk about briefly. We basically in the thin chamber in allergic disease and in food allergy are different than they do in dermatitis. For contact dermatitis, we use a 12 millimeter thin chamber aluminum foil. I do in my own clinic, I prepare my own food items with a standardized dilutions. We put the patch, we read the results after 2 days, 24 hours, and 72 hours. Okay, usually after 72 hours of removing the patch the day before, right? So remove the patch and see the patient at 72 hours. It's not a very common test, but with France, one of the main countries that does that test, in the Kuwait, I'm the only person who does that test at this time, unfortunately. Again, the patch testing is used for diagnosis for non-IgE mediated common protein allergy. Non-IgE mediated, okay? It's recent for the past, let's say, about 10 years or a bit more. It's reproducible in the back, okay? It is generally considered to be safe with risk of systemic reaction 1% or even less. I haven't experienced that, to be honest, in 10 years. It measures T-cell responses, not the IgE responses for food allergens or food proteins, okay? They've been done studies on cow milk and on egg and wheat. It has more diagnostic efficacy, let's say more sensitivity than skin prick testing for late response or non-IgE reactions, okay? Especially if you have a positive skin disorder such as eczema, okay? So we do it for eczema patients and we do it for eosinophilic esophagitis patients. That's the role for patch testing for common protein allergy. We do a panel. Okay, so it has high negative predictive value of more than 90%, as it is with IgE mediated disease and skin prick testing for IgE disease, but poor negative predictive value, okay, only about 50%. With IgE mediated milk allergy, the diagnostic tool, it's a clinical, obviously, diagnosis, but the most sensitive and golden test for diagnosis is a double-blind, placebo-controlled food challenge. Now, you have to keep in mind that this kind of challenge is difficult to perform. As well, it's a risk of anaphylaxis that you have to avoid in those patients. So this should not be done by a physician who has no experience in common protein allergy that's IgE mediated and does not have the experience with skin prick testing or serum IgE challenge or test, evaluation, and does not have the tools for anaphylaxis management. This is a specialized test, which is a challenge, only done by the expert allergist who has experience in that field and analyzing the IgE disease. After usually 3 to 5 years of age, when the child can talk and give you the first signs of their symptoms, that's when you do the challenge with consent and with appropriate environment. You detect the IgE disease by testing for major and minor components, the alpha-lactoglobulins, the beta-lactoglobulins, the casein, either by skin testing, serum testing, as well. Intradermal testing is contraindicated, okay? So skin prick test, it could have been another poll, I didn't do it. Skin prick test is more sensitive in detecting IgE milk protein allergy, while serum IgE testing, the blood testing, is less sensitive in detecting IgE mediated allergy. So do not depend on blood testing. Okay, it could be as a screening test, but again, you have to be cautious about the analysis. Okay, and the basal activation test is new as well. It's been there for a few years now, about around 7 years or more or less. And you test for activated basals via the IgE receptor, where you have increased surface markers for CD63 and CD20, sorry, 203C, where the level of expression is measured by flow cytometry. Again, this is under evaluation. It's not been standardized, not approved yet. This is an important slide for everyone to understand. Okay, you can see this is a board where you have a soldier and you have innocent people on the other side. Okay, the border is not important where that is. Okay, but the soldiers are your IgE antibodies. They are your IgE antibodies against milk protein. The milk protein is there in your bloodstream, your GI tract after ingestion of milk. What happens next is unknown. They could attack or they could ignore. So just because you have IgE detected for cow protein or other proteins does not mean you have cow milk protein allergy. Okay? That's a very important take-home message. Please keep that in mind. Do not depend on testing for IgE disease to diagnose. It's only a tool to measure the antibody, not to measure the diagnosis clinically. The test is done very simple. In a very simple way, you put a drop of the milk. It could be a reagent, a component like a beta or a casein, or it could be a true milk, like an actual, natural milk. And you prick that with a small plastic or lancet or a metal lancet. It's harmless. It's not usually painful or a bit slightly uncomfortable. The results are apparent within 15 to 20 minutes as a sign of induration. We measure the induration in millimeters, and that gives you the diagnosis presence or the support of diagnosis. For common protein allergy, you need to have more than 6 millimeter measurement wheel in order to have 100% predictive value of common protein allergy. Now, the results more than 3 millimeters, okay, because it to be positive, but it does not always, as I say, mean you have a clinical diagnosis of common protein allergy. As well, it's very age dependent. For example, with egg, you need to have more than 7 if you're above 2 years of age to be confirmed 100% positive predictive value. If for peanuts, it has to be above 4, below 2 years of age, but above 8 to confirm it above 2 years of age. So at those numbers, it is confirmatory, right? Done properly, but it's difficult to measure and read and understand if you don't have the expertise in that regard. For blood testing, it's even more difficult to read. Okay, if you have results of more than 0.35, that means you have a positive result. But if you look at this Samson old study, which is a standard, like one of the landmark studies as well, for a 95% confidence, for a 90% or more, 98% positive predictive value, if you look at the count, okay, if you're under 2 years of age, okay, you need to have the results of 5 kilounits per liter or more, okay? That would be classified as class usually 2 or 3, depending on the results. Actually, this is class 3. This is class 3 when you look at the results panel and the reference ranges. That's the only time when you're about 95% sure this confirms your common protein allergy. The majority of children are under that number. Okay, if you look even, for example, here on the table into soy, you need to be more than 30 to be only 70% sure this is confirming the diagnosis. Okay, so just to show you why it's important not to read into the results with the blood and confirm that as a diagnosis. Often it does not confirm diagnosis unless you know about these tables and details and eventually do a challenge in some children. And the component testing helps you a little bit to understand. If you have alpha and beta lactoglobulin, we know these are labile, and so with heating, you reduce the chance of a reaction, and there is a high chance of tolerating baked cooked and baked items extensively that have those milk proteins. You will not have any symptoms. But if you have a casein component allergy in the child, then the chance of this being outgrown or heat affecting those children will become much less. Okay, so that helps the specialists know